Concomitant use of systemic agonists with monoamine oxidase inhibitors, tricyclic antidepressants, or methyldopa may infrequently lead to severe hypertension. The risk with aerosolized agents may be smaller. Adrenergic blockers, especially non-selective agents as propranolol and carv, dilol precipitate bronchospasm and increase the dose of agonist necessary to achieve bronchodilation. The risk of bronchospasm should be weighed against the potential benefits of blockers. One selective agents such as metoprolol, Toprol XL may be used carefully, for example, in the hospital in asthma patients when the risk-benefit ratio indicates such as in an acute myocardial infarction. C. Agonists should not be combined with other sympathomimetic agents because of additive cardiovascular effects. Vasoconstrictor and vasopressor effects of epinephrine are antagonized by adrenergic blocking agents, for example, phentolamine. The effects of agonists should be closely monitored in the elderly and in patients with a history of hyperthyroidism, diabetes, seizures, arrhythmias, and coronary artery disease. 2. Corticosteroids. Therapeutic effects. Corticosteroids suppress the inflammatory response and decrease airway hyperresponsiveness. B. Mechanism of action. Corticosteroids bind to glucocorticoid receptors on the cytoplasm of cells. The activated receptor regulates transcription of target genes. 1. Corticosteroids reduce inflammation via A. Inhibition of transcription and release of inflammatory genes. B. Increased transcription of anti-inflammatory genes that produce proteins that participate in or suppress the inflammatory process. 2. Clinical effects include I. Reduced production of inflammatory mediators. B. Enhanced adrenergic receptor expression, thus making the two agonists work better. C. Decreased mucus production. D. Prevention of endothelial and vascular leakage. Partial reversal of tissue remodeling. C. Administration and dosage. When there is no significant difference in the clinical efficacy of the corticosteroid agents currently available. The route of administration is determined by the condition of the patient. Systemic corticosteroids are used for rapid response during an exacerbation. Improvement in pulmonary function may begin within 1 to 3 HRS. However, the maximum effect is not achieved until 6 to 9 HRS or longer after administration. Supplemental doses should be administered to patients who are already taking systemic corticosteroids when they experience an exacerbation, even if the exacerbation is mild. 3. Intravenous corticosteroids, for example, methylprednisolone solumedrol, are administered to patients who are unable to take oral medications in severe exacerbations. Large doses, for example, methylprednisolone 60 mg or 125 mg intravenously, are quickly administered. However, patients can usually be switched to oral therapy as soon as they show clinical improvement and can tolerate oral medication. 844 Chapter 41I. Oral corticosteroids are acceptable as emergency treatment if the patient can tolerate the oral route and is not believed to be in imminent danger of respiratory arrest. Prednisone and prednisolone, Prelone, are the most frequently used oral corticosteroids. Prednisone and prednisolone are frequently administered in short bursts over 3 to 10 days. To treat exacerbations in the outpatient setting and in the emergency department. This type of regimen may also be used to rapidly achieve asthma control. During burst therapy, These agents may be administered for 3 to 10 days in 1 or 2 daily doses and then discontinued. When used in this fashion, tapering is not usually necessary but is often done by physicians. However, if a patient's condition appears to worsen after the last dose has been administered, it is reasonable to reinstitute the corticosteroid and then begin a tapering regimen. 5. Because inhaled corticosteroids are least likely to produce adverse reactions, the inhaled route should be used whenever possible for chronic treatment.
A.
Inhaled corticosteroids should not be used alone to treat serious acute exacerbations.
B.
Inhaled steroids are the preferred anti-inflammatory therapy for chronic asthma. C. In milder outpatient flares, doses of the inhaled steroids may be increased temporarily, although this is controversial and should not be done if in a combination inhaler of Xlaba. D. The number of corticosteroids available for inhalation therapy is increasing. The most recent additions are mometasone, Osmanex, and cyclizumide, Alvesco. Dosages of inhaled corticosteroids are provided in Table 41-5. When asthma control is achieved, attempts should be made to use the lowest effective dose to maintain. Table 41-5 estimated comparative daily dosages for inhaled corticosteroids. Low daily dose, medium daily dose, high daily dose. Drug in adult child, adult child, adult child. Beclomethasone, CFC, 42 or 84 grams, puff, 168, 504 grams, 84, 336 grams, 504 grams, 84, 336, 672 grams, 840 grams, 672 grams, HFA, 40 or 80 grams, 870, 40 grams, 240, 480 grams, 160, 320 grams, 480 grams, 320 grams, budesonide. DPI, 200 grams inhalation, 200, G200, 400 grams, 602, 200 grams, 600, 200 grams. Inhalation suspension, 0.5 milligrams, 1 milligram, 2 milligrams. For nebulization, child dose, flunisolide, 250 grams, puff, 500, 1,000 grams, 500. 750 grams, 1,000 grams, 1,000 grams, 5 grams, 500 grams, 5. 1,250 grams fluticasone. In DIB 44, 110, or 88, 264 grams. The 88, 176 grams, 264, 660 grams, 176, 440 grams, 60 grams, 460 grams, 160 grams. DPI 50, 100, or 100, 300 grams, 100, 200 grams, 300 grams, 100 grams, 200 grams, 100 grams, 200 grams, 400 grams. $250 grams inhalation mometasone. DPI 200 grams inhalation, 200 grams NZA 400 grams ND 400 grams ND. Not approved for persons 12 years old. Triamcinolone, 100 grams puff, 400, 1,000 G, 400,000 grams, 2,000 grams, 800 grams, 200 grams, 2,000 grams, 1,000, 200 grams. In all cases, the lowest dose to maintain control should be used. Some doses are outside package labeling. BMDI doses are actuator doses. That is, amount-leaving actuator. CFC, chlorofluorocarbons, DPI, dry powder inhaler, HFA, hydroxyuroalkanase, MDI, metered dose inhaler. Modified from National Asthma Education and Prevention Program Expert Panel Report Guidelines for the Diagnosis and Management of Asthma, NHLBI Asthma Guidelines 2007. August 2007. Asthma and chronic obstructive pulmonary disease 845. Control. Step-down therapy. Side effects of inhaled steroids and systemic steroids are dose-dependent. Inhaled corticosteroids are considered first-line anti-inflammatory therapy for mild to severe persistent asthma in both adults and children. 6. Treatment of asthma exacerbation in adults. For treatment of a severe exacerbation, prednisone may be given at a dose of 2 mg kg, maximum of 60 mg. For intravenous treatment, methylprednisolone is given at a dosage of 120 to 180 milligrams a day in 3 or 4 divided doses for 48 HRS or until the patient can tolerate oral medications. The dosage is then reduced to 60 to 80 milligrams a day until PEFR reaches 70% predicted or personal best. B. For outpatient burst therapy, the dosage of prednisone is 1 to 2 milligrams a kg a day, maximum of 60 milligrams c, in 1 or 2 divided doses for 3 to 10 days. 7. Treatment of asthma exacerbation in children. For inpatient treatment of a severe exacerbation, prednisone, methylprednisolone, or prednisolone is given at a dosage of 1 mg per kg every 6 HRS for 48 HRS. The dosage is then reduced to 1 to 2 mg kg a day, maximum of 60 mg a day, in 2 divided doses until PEFR is 70% predicted or personal best. B. For outpatient burst therapy, the dosage of prednisone is 1 to 2 milligrams a kg a day, maximum of 60 milligrams c, in 1 or 2 divided doses for 3 to 10 days. D. Precautions and monitoring effects. 1. Systemic corticosteroids. Careful monitoring is necessary in patients with diabetes. Steroids commonly increase blood sugar, hypertension, adrenal suppression, congestive heart failure, fluid retention owing to mineralocorticoid effects, peptic ulcer disease, candidiasis, immunosuppression, osteoporosis, chronic infections, cataracts, glaucoma, myasthenia gravis, and psychiatric diseases, for example, depression, psychosis. Some of these side effects begin shortly after beginning systemic steroids, for example, hyperglycemia, whereas others, for example, osteoporosis, only occur with long-term use. B. If a prolonged course of systemic therapy is necessary to maintain asthma control, interference with the hypothalamic pituitary adrenal axis is lessened by a single morning dose, that is, 6 to 8 or alternate day therapy. For alternate day therapy, the dose is twice that of the single morning dose. Patients on regular systemic therapy should be closely monitored and should receive regular ophthalmological evaluations and osteoporosis screening. In preventative therapy, for example, calcium, vitamin D, bisphosphonates, if indicated. 2. Inhaled corticosteroids. Local effects associated with inhaled corticosteroids include hoarseness, dysphonia, and fungal infection, candidiasis of the mouth and throat. Local side effects can be lessened through mouth rinsing, use of a spacer, and use of certain inhaled steroid products. B. The U.S. Food and Drug Administration, the FDA, includes warning labels on inhaled corticosteroid products to include dose-related slowing of growth velocity in children, approximately 1/3 in per year. Shortly after the labeling was revised, two major publications demonstrated short-term growth suppression of approximately 1 centimeter in the first year of budesonide treatment, but without long-term effects on final adult height. However, children should be treated with the lowest effective dose and should be reminded that poorly controlled asthma also slows growth. C. Large doses of inhaled corticosteroids may result in systemic effects, such as reduced bone density, changes in adrenal function, skin changes, adrenal suppression, and cataract formation. Further study is needed to fully understand these effects and to determine their clinical significance. However, patients receiving high doses of inhaled corticosteroids should be closely monitored and should receive regular ophthalmological evaluations and osteoporosis screening and treatment, for example, calcium, vitamin D, if indicated. D. Spacers, for example, air chamber, are generally prescribed for patients who receive moderate to high doses of inhaled corticosteroids via NDIs. Patients should also 846, Chapter 41. I gargle, rinse their mouth and throat, and expectorate after administration. Both of these interventions minimize oropharyngeal drug deposition, local adverse reactions, and gastrointestinal absorption. I. Steroids and dry powder inhalers, Pulmicort Flexhaler, generally have a lower incidence of local side effects due to smaller particle size and less oropharyngeal deposition. A new form of beclomethasone, MDI, also has a low incidence of local side effects due to relatively low oropharyngeal deposition. 3. Significant interactions, a concurrent use of hepatic microsomal enzyme inducers. For example, rifampin, barbiturates, hydantoins, causes enhanced corticosteroid metabolism, reducing therapeutic efficacy. B. Concurrent use of estrogens, oral contraceptives, itraconazole, sporanox, or macrolide antibiotics, for example, erythromycin, clarithromycin, Neoxin, may decrease corticosteroid clearance. C. Cyclosporin may increase the plasma concentration of corticosteroids. Administration of potassium-depleting diuretics, for example, thiazides, furosemide, or other potassium-depleting drugs, for example, amphotericin, with corticosteroids causes enhanced hypokalemia. Serum potassium should be closely monitored, especially in patients on digitalis glycosides. 3. Leukotriene modifiers are the newest agents with anti-inflammatory properties to be approved for use in asthma. Leukotrienes are important participants in asthma pathophysiology. Cellular effects of leukotrienes include enhanced migration of eosinophils and neutrophils, increased adhesion of leukocytes, and increased monocyte and neutrophil aggregation. Leukotrienes also increase capillary permeability and cause smooth muscle contraction. Leukotriene modifiers currently available in the United States include montelukast, zafirlukast acrylate, and Xilutone. Zaflo. 1. Therapeutic effects of leukotriene modifiers have anti-inflammatory and bronchodilator activity. They may allow reduction in corticosteroid doses in some patients. B. Because they may be less effective anti-inflammatory agents than inhaled corticosteroids, they are considered second-line agents. C. In children, for whom administration of inhaled drugs is challenging, oral leukotriene receptor antagonists may be particularly useful. D. They may be useful in patients with concurrent allergic rhinitis and asthma. 2. Mechanism of action. The leukotriene receptor antagonists are selective cysteinoleukotriene 1, T-1 receptor antagonists. Therefore, they prevent leukotrienes from interacting with their receptors. Xilutone, a leukotriene modifier, blocks the effects of 5-lipoxygenase and ultimately blocks leukotriene production. Administration and dosage. The dosage of zafirlukast in children 12 years and adults is 20 mg twice daily. Food reduces bioavailability, so zafirlukast should be taken at least 1 HR before or 2 HRs after meals. Children 5 to 11 years of age should receive 10 mg twice daily. B. The dosage of montelukast in adolescents 15 years of age or older and adults is 1 10 mg tablet once every evening. The dosage for children 6 to 14 years of age is 1 5 mg chewable tablet once every evening. Children ages 2 to 5 should receive 1 4 mg chewable tablet once every evening. Food does not appear to change bioavailability. 4. Precautions and monitoring effects. Adverse reactions to montelukast are uncommon and include headache, dizziness, and dyspepsia. B. Adverse reactions associated with zafirlukast include headache, dizziness, nausea, and diarrhea. C. Churg-Strauss syndrome, a form of eosinophilic vasculitis, has rarely been associated with zafirlukast, montelukast, and pranlukast, available in Japan. It has usually, but not always, occurred in patients whose chronic steroid regimens were tapered and discontinued. At-risk patients should be monitored. 4. Precautions and monitoring effects. Adverse reactions to montelukast are uncommon and include headache, dizziness, and dyspepsia. B. Adverse reactions associated with zafirlukast include headache, dizziness, nausea, and diarrhea. C. Churg-Strauss syndrome, a form of eosinophilic vasculitis, has rarely been associated with zafirlukast, montelukast, and pranlukast, available in Japan. It has usually, but not always, occurred in patients whose chronic steroid regimens were tapered and discontinued. At-risk patients should be monitored for vasculitic rash, eosinophilia, and increasing pulmonary, cardiac, and neuropathic symptoms. Asthma and chronic obstructive pulmonary disease. 847. Significant drug interactions may occur. I. Aspirin increases zafirlukast levels. Erythromycin, theophylline, and terfenadine decrease zafirlukast concentrations. The third. Zafirlukast may increase the anticoagulant effect of warfarin and levels of dofetilide. Drug interactions appear to be less significant with montelukast. Patients who are receiving montelukast with hepatic enzyme inducers, for example, rifampin, phenobarbital, should be monitored closely. The chewable forms of montelukast, 4 and 5 mg tablets contain aspartame and should be avoided in patients with phenylketonuria. B. The only lipoxygenase inhibitor approved by the FDA is Xileuton, Xiflo. Xileuton may allow reduction in corticosteroid doses in some patients. 1. Therapeutic effects. Lipoxygenase inhibitors have anti-inflammatory and bronchodilator activity. Mechanism of action. Lipoxygenase inhibitors prevent the formation of leukotrienes. Xileuton blocks 5-lipoxygenase, the enzyme responsible for leukotriene formation. 3. Administration and dosage. In adults and children 12 years of age and older, the dosage of Xileuton is 600 mg 4 times daily. It may be taken without regard to meals. A new formulation, Xileuton CR, may be dosed twice daily. 4. Precautions and monitoring effects. Xileuton is contraindicated in patients with hepatic function impairment and should be monitored closely in patients who drink large quantities of alcohol. B. Adverse effects include headache, abdominal pain, asthenia, nausea, dyspepsia, and myalgia. Drug therapy was discontinued in almost 10% of patients owing to side effects, although this was similar to placebo. C. Significant drug interactions may occur. I. Xileuton increases concentrations of propranolol, terfenadine, and theophylline. The anticoagulant effect of warfarin is increased by Xileuton. D. Hepatic enzymes, for example, alanine aminotransferase, ALT, may become elevated during therapy, with most occurrences during the first several months of therapy. Symptomatic hepatitis has been reported. Therefore, the manufacturer recommends that serum ALT be checked before initiation of treatment, monthly for 3 months, and every 2 to 3 months for the rest of the first year. ALT should be checked periodically thereafter. Patients should be monitored closely for signs or symptoms of liver dysfunction. The anticoagulant effect of warfarin is increased by Xileuton. D. Hepatic enzymes, for example, alanine aminotransferase, ALT, may become elevated during therapy, with most occurrences during the first several months of therapy. Symptomatic hepatitis has been reported. Therefore, the manufacturer recommends that serum ALT be checked before initiation of treatment, monthly for 3 months, and every 2 to 3 months for the rest of the first year. ALT should be checked periodically thereafter. Patients should be monitored closely for signs or symptoms of liver dysfunction. For example, right upper quadrant abdominal pain, flu-like symptoms, fatigue, nausea, lethargy, itching, jaundice. If ALT increases to more than 5 times the upper limit of normal, therapy should be discontinued and the patient should be monitored until enzymes normalize. 4. Cromolyn A. Therapeutic effects. Cromolyn is currently only available as a nebulized solution for the treatment of asthma. Nitochromil and cromolyn MDIs have been removed from the market. Cromolyn is less effective in its anti-inflammatory properties than the inhaled steroids, however, because of its excellent safety profile, is sometimes still used in children. 1. When used prophylactically, cromolyn prevents the early and late response of asthma. When used as maintenance therapy for asthma, this medication suppresses nonspecific airway reactivity. B. Mechanism of action. Cromolyn is believed to act locally by stabilizing mast cells and thereby inhibiting mast cell degranulation. C. Administration and dosage. 1 cromolyn is available as a nebulized solution in 2 ml ampules containing 20 mg and is administered as often as 4 times a day. 2. When used as prophylaxis of EIB, it should be used. Therapeutic effects. Cromolyn is currently only available as a nebulized solution for the treatment of asthma. Nitochromil and cromolyn NDIs have been removed from the market. Cromolyn is less effective in its anti-inflammatory properties than the inhaled steroids, however, because of its excellent safety profile is sometimes still used in children. 1. When used prophylactically, cromolyn prevents the early and late response of asthma. While when used as maintenance therapy for asthma, this medication suppresses nonspecific airway reactivity. B. Mechanism of action. Cromolyn is believed to act locally by stabilizing mast cells and thereby inhibiting mast cell degranulation. C. Administration and dosage. 1 cromolyn is available as a nebulized solution in 2 ml ampules containing 20 mg and is administered as often as 4 times a day. 2. When used as prophylaxis of EIB, it should be used 30 minutes prior to exercise. 3. After administration, initial improvement is seen within 1 to 2 weeks. However, the maximum effect may take longer. 848, Chapter 41 D. Precautions and monitoring effects. Cromolyn is not effective during an acute asthma exacerbation. It should be used only for maintenance therapy of persistent asthma or for prevention of EI. 2. It is well tolerated, although paradoxical bronchospasm, wheezing, coughing, nasal congestion, and irritation or dryness of the throat may occur. 5. Theophylline compounds, methylxanthines. A. Indications. 1. Theophylline compounds may be considered if agonists and corticosteroids fail to control an acute asthma exacerbation. 2. Theophylline is an alternative to long-acting agonists in the treatment of persistent asthma. 3. Theophylline is most beneficial as an adjuvant to inhaled corticosteroids in patients with nocturnal or early morning symptoms. B. Therapeutic effects. 1. Theophylline compounds produce bronchodilation to a lesser extent than agonists. 2. Non-bronchodilator effects include reduced mucus secretion, enhanced mucociliary transport, improved diaphragmatic contractility, and possibly reduced fatigability. 3. There may also be notable degree of anti-inflammatory activity. C. Mechanism of action. Theophylline-induced phosphodiesterase inhibition results in increased levels of CAMP. D. Administration and dosage. 1. Oral therapy, for example, sustained-release theophylline allows for a longer dosing interval and improves compliance. Compliance to oral theophylline also may be better than that of inhaled bronchodilators and corticosteroids. A. Because theophylline does not distribute well into fatty tissue, dosages should be calculated using lean body weight. B. The initial dose of theophylline for adults and children age 1 is 10 mg kg a day, maximum of 300 mg a day, given in divided doses. Usual dosage should be adjusted to achieve serum theophylline concentration of 5 to 15 grams cml. 5 to 10 grams cml acceptable. C. The dosage can be titrated slowly upward and the serum level monitored until a therapeutic level is obtained. D. The usual maximal daily dose in adults is 800 mg a day. The maximum recommended dosage in children age 1 is 0.2, age in weeks 5 mg Hg a day, and in children 1 year is 16 mg Ckg a day, given in divided doses. Ultra-sustained release theophylline formulations, Theominus 24 and Unifil, may be dosed once daily. In addition to theophylline, other methylxanthine compounds are available, for example, oxtrafylline, diphyline, but infrequently used. Dosing of these compounds is based on theophylline content. Table 41-6. Intravenous therapy. Although frequently used in the past, IV administration is now uncommon. IV administration is generally used only in hospitalized patients for whom oral therapy is not possible. For example, vomiting, nothing by mouth. The usual loading dose for adults and children not previously receiving a methylxanthine is 5 mg Ckg of theophylline administered over 20 to 30 mins at a rate not exceeding 25 mg min. Table 41-6 Theophylline content of theophylline-containing products. Preparation theophylline content. Equivalent dose, mg. Theophylline anhydrous, most oral solids. 100 and 100 theophylline monohydrate, oral solutions. 91-110 aminophylline anhydrous, 86-116 aminophylline anhydrous, 79. 127 oxtrafylline, 64-156. Asthma and chronic obstructive pulmonary disease, 849. Asthma and chronic obstructive pulmonary disease, 849. The usual maintenance infusion rate of theophylline in healthy non-smoking adults on no interacting drugs is 0.4 ng/h. This rate should be adjusted for factors that affect theophylline metabolism and serum levels. See Table 41-7. Precautions and monitoring effects. 1. Theophylline are contraindicated in patients with hypersensitivity to xanthine compounds and should be used cautiously in patients with a history of peptic ulcer or untreated seizure disorder. 2. Adverse effects include nausea, vomiting, diarrhea, anorexia, palpitations, dizziness, restlessness, nervousness, insomnia, seizures, reduce lower esophageal sphincter tone, and reduce control of gastroesophageal reflux disease. Patients who experience adverse gastrointestinal effects should be evaluated to rule out theophylline toxicity versus local gastrointestinal effect. 3. Theophylline clearance can be altered by several factors and drug interactions. Table 41-7. Close drug level monitoring is required for patients with factors that alter theophylline clearance. 4. Careful monitoring is required in patients with hepatic disease, hypoxemia, hypertension, congestive heart failure, alcoholism, and in the elderly. Because of developmental. Table 41-7 factors that alter theophylline clearance. Factors that increase theophylline clearance, decrease levels. Age 1, 9 years drugs. Carbamazepine phenobarbital phenytoin rifampin fever food may delay or reduce absorption of some sustained-release products, high-protein diet, smoking, marijuana and tobacco. Factors that decrease theophylline clearance, increase levels. Age. Elderly premature neonates term infants 6 months core pulmonary congestive heart failure. Decompensated drugs. Allopurinol blockers. Non-selective calcium channel blockers cimetidine fluoroquinolones. Ciprofloxacin influenza virus vaccine macrolides. Clarithromycin. Erythromycin oral contraceptives ticlopidine zafiru cost fever viral illness fatty foods may increase rate of absorption of some products high carbohydrate diet liver dysfunction, for example, cirrhosis. 850 Chapter 41 I. Changes in the neonate and child. Dosing must be carefully established and monitored in these populations as well. 5. Therapeutic drug monitoring of serum levels, adverse reactions, and concomitant drug use is essential for long-term therapy owing to theophylline's age and condition-specific clearance. A. Therapeutic effect is achieved and toxicity minimized by keeping drug concentrations at 5 to 15 grams cml. B. Drug levels should be assessed at steady state, typical half-life 8 HRs, up to 24 HRs in severe heart and liver failure. C. During oral therapy, trough drug levels should be obtained, essential for long-term therapy owing to theophylline's age and condition-specific clearance. A. Therapeutic effect is achieved and toxicity minimized by keeping drug concentrations at 5 to 15 grams cml. B. Drug levels should be assessed at steady state, typical half-life 8 HRs, up to 24 HRs in severe heart and liver failure. C. During oral therapy, trough drug levels should be obtained at steady state. D. Diphyline serum levels should be monitored during therapy because serum theophylline levels will not measure diphyline. The minimal effective therapeutic concentration of diphyline is 12 grams cml. 6. Anticholinergics. Bronchodilation occurs when these drugs block postganglionic muscarinic receptors in the airway. Response to anticholinergics is most pronounced in patients with fixed airway obstruction, for example, COPD, but may have a role in combination with agonists. A. Ipratropium bromide. Atrovent is a quaternary ammonium compound. 1. Indications. Ipratropium bromide is recommended for use in combination with agonists for the treatment of an acute asthma exacerbation in the emergency department or hospital settings. However, benefits in the chronic management of asthma have not been established. B. Ipratropium bromide may be particularly useful in older patients and patients with coexisting COPD. C. Ipratropium should not be used alone to treat an asthma exacerbation. D. Ipratropium bromide is an alternative bronchodilator in some patients who cannot tolerate agonists and in patients who present with bronchospasm induced by a blocker. 2. Administration and dosage. A. Closed-mouth MDI technique, or the use of a spacer is recommended for patients receiving anticholinergic therapy via MDI. 2. Administration and dosage. A. Giving anticholinergic therapy via MDI. A. Ipratropium bromide. Atrovent is a quaternary ammonium compound. 1. Indications. Ipratropium bromide is recommended for use in combination with agonists for the treatment of an acute asthma exacerbation in the emergency department or hospital settings. However, benefits in the chronic management of asthma have not been established. B. Ipratropium bromide may be particularly useful in older patients and patients with coexisting COPD. C. Ipratropium should not be used alone to treat an asthma exacerbation. D. Ipratropium bromide is an alternative bronchodilator in some patients who cannot tolerate agonists and in patients who present with bronchospasm induced by a blocker. 2. Administration and dosage. A closed-mouth MDI technique, or the use of a spacer, is recommended for patients receiving anticholinergic therapy via MDI. B. The starting dose of the MDI is 2 inhalations 4 times a day. When administered via nebulizer, the dose is 500 grams 2.5 milliliters 4 times a day. 3. Precautions and monitoring effects. As the anticholinergic spray contacts the eye, intraocular pressure may increase. B. The onset of action, approximately 15 mins, and peak effect, 1 to 2 HRS, are more delayed than for agonists. B. Aerosolized atropine is used rarely now that ipratropium bromide nebulization solution is available owing to atropine's high incidence of systemic adverse effects. 7. Antihistamines are useful for patients with coexisting allergic rhinitis. However, their role in the treatment of asthma remains unclear. Antihistamines compete with histamine for hormone receptor sites on effector cells, and thus help prevent the histamine-mediated responses that influence asthma. 8. Antibiotics are generally not used for the treatment of asthma, unless other signs of infection are present. 9. Magnesium sulfate, administered intravenously, may be useful in some patients because of its modest ability to cause bronchodilation. When administered intravenously, it also improves respiratory muscle strength in hypomagnesemic patients. Research has suggested that magnesium may reduce admission rate and improve FeVO in severe, acute asthma exacerbations and in stable, chronic asthma. 10. Immunotherapy allergy shots improves asthma control in some patients and is ineffective in others. A recent meta-analysis demonstrated that immunotherapy may improve lung function, reduce symptoms, and decrease medication requirements in a significant number of patients. 11. Mucus may contribute to airway obstruction in asthma. However, because some inhaled mucolytics such as acetylcysteine may precipitate bronchospasm, they should not be used for the treatment of patients with asthma. 12. Omalizumab Xolair is an anti-IgE compound used for severe asthma and concurrent allergies. It is usually administered twice monthly as an injection in a specialty physician's office. Life-threatening anaphylaxis has rarely been reported with this medication. Asthma and chronic obstructive pulmonary disease 851. J. Drug delivery options. 1. MDIs. A. When administered with good technique and a spacer, the efficacy of MDIs is similar to that of nebulizers, despite the lower doses administered with an MDI and spacer. The only MDI that comes with a built-in spacer is the Asthmacort triamcinolone inhaler. B. For small children to be able to use an MDI, a spacer with a face mask must be used. C. MDIs can be difficult to use. Steps for properly using an MDI are outlined in Table 41-8. D. MDIs can be administered to patients on mechanical ventilation with the use of an attachment device designed for the mechanical ventilator circuit. Higher doses of the two agonists are often used in this setting. E. Breath-actuated MDIs, for example, Maxair Autohaler, require the patient to use a closed-mouth technique. When inhalation has begun, the medication is released automatically. This type of inhaler is useful for a patient who is having problems coordinating actuation and inhalation. 2. Spacers and holding chambers, for example, aerochamber, aerovent, ellipse, inspiries, optochamber. A. Spacers and holding chambers reduce the amount of drug deposited in the oral cavity. B. The use of spacers and holding chambers may minimize local and systemic adverse reactions. C. Addition of a spacer in a patient with poor MDI technique may improve pulmonary delivery of the agent. D. Spacers should be considered in all patients who are receiving medium to high doses of inhaled corticosteroids. E. They are especially beneficial for patients with poor hand-lung coordination, such as very young and old. Devices vary in construction and efficacy. The presence of a one-way mouthpiece valve, inhalation rate whistle, size, and durability are all factors that should be considered when selecting a particular spacer for a patient. Some new spacers have antistatic interiors to minimize adherence of aerosol particles to the interior of the spacer. 3. Nebulizers. Compared to MDI and spacer administration, nebulizers require less patient coordination during administration of multiple inhalations. B. Disadvantages of nebulizers include cost, preparation and administration time, size of the device, and drug delivery inconsistencies among devices. C. Despite the disadvantages, nebulization is recommended for delivery of high-dose agonists and anticholinergics in severe exacerbations. 4. Dry powder inhalers. Dry powder inhalers DPIs are coming to the market as a result of the international move to avoid the use of chlorofluorocarbon (CFC) propellants. They are also being used more frequently because many patients find them easier to use than an MDI. Table 41-8 procedure for the proper use of metered dose inhalers. MDIs. Assemble MDI if necessary. Remove cap and inspect mouthpiece for foreign objects. Attach MDI to spacer if applicable. Shake MDI with spacer. Tilt head back slightly and exhale fully. Position inhaler. Wrap lips around spacer mouthpiece. Position inhaler 1, 2 in, from open mouth. Wrap lips around inhaler mouthpiece. Just as you begin to inhale, depress canister once to release medication. Continue inhaling slowly over 3-5 c's until lungs are full. Hold breath for 5. Wait 1 minute before repeating steps to deliver additional puffs. Rinse mouth out after use of inhaled steroids. 852 Chapter 41I. J. B. Dry powder inhalers require the user to first load the dose into the delivery chamber, 2 exhale fully, 3 inhale rapidly or slowly, depending on the device, versus only slow inhalation required for NDI. Administration. 4. Use the closed mouth technique. Avoid exhaling into the mouthpiece before inhalation. C. Spacers are not used with DPI. D. Patients should be advised to keep these devices away from moisture. K. Non-pharmacological treatment. 1. Humidified oxygen is administered to all patients with severe, acute asthma to reverse hypoxemia. Although the fraction of inspired oxygen, IO2 administered is based on the patient's arterial blood gas status, 1 to 3 Ll/min is generally given via face mask or nasal cannula. The goal is to keep the IO2 90%, 95% if the patient is pregnant or has heart disease. 2. Heliox is a mixture of helium and oxygen that has a lower density than air. Because of its decreased airflow resistance, heliox may increase ventilation during acute asthma exacerbations. Because conflicting information has been published in studies using heliox, its role in asthma is unclear. 3. Intravenous fluids and electrolytes may be required if the patient is volume depleted. 4. Environmental control and allergen avoidance are important in the management of a patient with asthma. Available data suggests that avoidance of known allergens can improve asthma control. B. Some measures include use of allergen-resistant mattress and pillow encasements, use of high-filtration vacuum cleaners, removal of carpets and draperies, and avoidance of furry pets. 5. Vaccines, for example, influenza virus, polyvalent pneumococcals, are recommended to prevent infection, which may precipitate an exacerbation. Second, chronic obstructive pulmonary disease. Definitions. The National Heart, Lung, and Blood Institute, World Health Organization. NHLB WHO Global Initiative for Chronic Obstructive Lung Disease. Gold definition of COPD is a disease state characterized by airflow limitation that is not fully reversible. The airflow limitation is usually both progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. The American Thoracic Society definition is similar. A disease state characterized by the presence of airflow limitation owing to chronic bronchitis or emphysema. The airflow obstruction is generally progressive, may be accompanied by airway hyperreactivity, and may be partially reversible. The two major forms of COPD, chronic bronchitis and emphysema, frequently coexist. COPD also coexists with asthma. These guidelines have been updated annually. 1. Chronic bronchitis is characterized by excessive mucus production by the tracheobronchial tree, which results in airway obstruction as a result of edema and bronchial inflammation. Bronchitis is considered chronic when the patient has a cough producing more than 30 milliliters of sputum in 24 HRs for at least 3 months of the year for 2 consecutive years, and other causes of chronic cough have been excluded. 2. Emphysema is marked by permanent alveolar enlargement distal to the terminal bronchioles and destructive changes of the alveolar walls. There is a lack of uniformity in airspace enlargement, resulting in loss of alveolar surface area. The collapse of these small airways results in airflow limitation that is independent of exertion. B. Incidence. Approximately 17 million Americans have COPD. COPD is the third leading cause of death in the United States and the leading cause of hospitalization in the older population. It is most commonly diagnosed in older men. However, the incidence is increasing in women owing to an increasing population of women smokers. Women may be more likely to have more rapidly progressive COPD than men. Asthma is a common comorbidity. C. Cause. Various factors have been implicated in the development of COPD, including the following. 1. Cigarette smoking is the primary causal factor for the development of COPD, present in 90% of patients. One mechanism suggests that pulmonary hyperreactivity secondary to smoking results in persistent airway obstruction. Asthma and chronic obstructive pulmonary disease 853. B. There is also an increased risk of COPD in people who have 1-antitrypsin deficiency. 1 in 3 people with genetic 8 deficiency develop emphysema, usually as young adults. 1. AAT is a serine protease inhibitor, and it is also an acute phase reactive protein. The major physiological function of AAT is inhibition of neutrophil elastase. 2. AAT deficiency should be suspected when emphysema develops early in the absence of a significant smoking history. 2. Exposure to irritants such as sulfur dioxide, as in polluted air, noxious gases, and organic or inorganic dust or combustible fuels in the home. 3. A history of respiratory infections or bronchial hyperreactivity. 4. Social, economic, and hereditary factors. D. Pathophysiology. 1. Chronic bronchitis. A. Respiratory tissue inflammation results in vasodilation, congestion, mucosal edema, and goblet cell hypertrophy. These events trigger goblet cells to produce excessive amounts of mucus. B. Changes in tissue include increased smooth muscle, cartilage atrophy, infiltration of neutrophils and other cells, and impairment of cilia. C. Airways become blocked by thick, tenacious mucus secretions, which trigger a productive cough. D. Normally, sterile airways can become colonized with Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, Staphylococcus aureus, and Pseudomonas aeruginosa species. Recurrent lung infections, viral and bacterial, reduce ciliary and phagocytic activity, increase mucus accumulation, weaken the body's defenses, and further destroy small bronchioles. E. As the airways degenerate, overall gas exchange is impaired, causing exertional dyspnea. F. Hypoxemia results from a VCQ imbalance and is reflected in an increasing arterial carbon dioxide tension, that is, increasing PaCO2. G. Sustained hypercapnia, increased PaCO2, desensitizes the brain's respiratory control center and central chemoreceptors. As a result, compensatory action to correct hypoxemia and hypercapnia, that is, a respiratory rate or depth increase, does not occur. Instead, hypoxemia serves as the stimulus for breathing. Use of narcotics or benzodiazepines, especially in combination, should be done cautiously in these patients to avoid respiratory failure. 2. Emphysema. Anatomical changes are the result of loss of tissue elasticity. 1. Inflammation and excessive mucus secretion, as from long-standing chronic bronchitis, cause air trapping in the alveoli. This contributes to breakdown of the bronchioles, alveolar walls, and connective tissue. 2. As clusters of alveoli merge, the number of alveoli diminishes, leading to increased space available for air trapping. 3. Destruction of alveolar walls causes collapse of small airways on exhalation and disruption of the pulmonary capillary beds. 4. These changes result in VCQ abnormalities. Blood is shunted away from destroyed areas to maintain a constant VCQ ratio, unlike the case in chronic bronchitis. 5. Hypercapnia and respiratory acidosis are uncommon in emphysema because VCQ imbalance is compensated for by an increased respiratory rate. B. There are specific regions of the lung in which characteristic anatomical changes of emphysema occur. In centrilobular centriacinar, emphysema associated with cigarette smoking, destruction is central, selectively involving respiratory bronchioles. Typically, bronchioles and alveolar ducts become dilated and merge. In panlobular, panacinar emphysema, all lung segments are involved. The alveoli enlarge and atrophy, and the pulmonary vascular bed is destroyed. This form of emphysema is associated with OT deficiency. In paraseptal emphysema, the lung periphery adjacent to fibrotic regions is the site of alveolar distension and alveolar wall destruction. This is associated with spontaneous pneumothorax. 854 Chapter 41 2 Clinical Evaluation 1. Physical findings. Predominant chronic bronchitis typically has an insidious onset after age 45. 1. A chronic productive cough is the hallmark of chronic bronchitis. It occurs first in winter, then progresses to year-round. It is usually worse in the morning. Smoking cessation can help lessen the productive cough. Exertional dyspnea, the most common presenting symptom, is progressive. However, the severity of this symptom may not reflect the severity of the disease. 3. Other common findings include obesity, rhonchi and wheezes on auscultation, prolonged expiration, and a normal respiratory rate. As the disease progresses, right ventricular failure is common, which presents as jugular venous distension, peripheral edema, hepatomegaly, and cardiomegaly. Because patients tend to develop cyanosis, the term blue bloater is sometimes used to describe patients with chronic bronchitis. B. Predominant emphysema has an insidious onset, and symptoms occur after age 55. 1. The cough is chronic but less productive than in chronic bronchitis. 2. Exertional dyspnea is progressive, constant, severe, more characteristic of emphysema than chronic bronchitis. 3. Other common findings include weight loss, tachypnea, pursed lip breathing, prolonged expiration, accessory chest muscle use, hyperresonance on percussion, diaphragmatic excursion, and diminished breath sounds. Because patients are able to maintain reasonably good oxygenation because of their tachypnea, the term pink puffer is sometimes used to describe patients with emphysema. Note, however, that the pink puffer and blue bloater presentations are not specific for the respective diseases. C. Patients may have elements and physical findings from each of these diseases simultaneously. Comorbidities such as THF, CAD, stroke, direct message, and depression are common in COPD patients. 2. Diagnostic test results. A. COPD patients with characteristic symptoms of cough, dyspnea, sputum production, and EO exposure to known risk factors, for example, smoking, should be evaluated for a COPD diagnosis. If the patient has pneumonia thesis 70% and a postbronchodilator pneumonia 80% predicted, he or she has airflow limitation that is not fully reversible. Patients with a smoking history, for example, 20-pack year history and 45 years old, should be considered for the diagnosis. Spirometry can be used to help make the diagnosis. B. Chronic bronchitis. Blood analysis may reveal polycythemia, as a result of erythropoiesis secondary to hypoxemia. With bacterial infection, the WBC count may be increased. 2. Sputum inspection reveals thick purulent or mucopurulent sputum tinged yellow, white, green, or gray. An acute change in color and/or quantity suggests infection. 3. Arterial blood gas studies may show a markedly decreased PaO2 level, 45 to 60 mg/Hg, reflecting hypoxemia, and a PaO2 level that is normal or elevated, 50 to 60 mg/Hg, reflecting hypercapnia. Pulmonary function tests may be normal in the early disease stages. Later, they show a reduced FeVO/FVC ratio, increased residual lung volume, a decreased vital capacity, and a decreased FeVO. Unlike emphysema, chronic bronchitis patients tend to have normal diffusing capacity, normal static lung compliance, and normal TLC. Chest radiograph typically identifies lung hyperinflation, a barrel chest, and increased bronchovascular markings. 6. An ECG may reveal right ventricular hypertrophy and changes consistent with cor pulmonale. C. Emphysema of sputum. Sputum inspection reveals scanty sputum that is clear or mucoid. Infections are less frequent than in chronic bronchitis. Arterial blood gas studies typically indicate a reduced or normal PaO2 level, 65 to 75 mg/Hg, and, in late disease stages, an increased PaO2 level, 50 to 60 mg/Hg. Pulmonary function tests show a reduced FeVO/FVC ratio, normal or increased static lung compliance, reduced FeVO and diffusing capacity, and increased TLC and RV. Asthma and chronic obstructive pulmonary disease 855. 4. Chest radiograph usually reveals bullae, blebs, a flattened diaphragm, lung hyperinflation, vertical heart, enlarged anteroposterior chest diameter, decreased vascular markings in the lung periphery, and a large retrosternal airspace. F. Treatment objectives endorsed by GOLD include the following. 1. Prevent disease progression, smoking cessation. 2. Relieve symptoms and improve exercise tolerance. Enable the patient to perform normal daily activities. 3. Improve health status. 4. Prevent and treat exacerbations. 5. Prevent and treat complications. 6. Reduce mortality. G. Therapy. 1. Pharmacological treatment. Therapy is based on disease staging, which is determined by spirometry, Table 41-9. Short-acting anticholinergics and agonists, alone or in combination, are the most commonly used initial agents. Long-acting bronchodilators, such as salmeterol, formoterol, tiotropium, Spiriva, and theophylline are added to the short-acting agents. Methoxanthines are usually added when the response to other agents is inadequate. In addition to bronchodilation, these agents can decrease dyspnea, improve exercise capacity, improve quality of life, and decrease the frequency and severity of exacerbations, especially tiotropium. A new agent was recently approved, roflumilast, Daliresp, in the United States. It is a selective PDE4 inhibitor that is indicated to decrease COPD exacerbations in certain patients. B. Bronchodilators are the most important therapy for symptoms in COPD. Figure 41-4 indicates a strategy of use. C. Inhaled corticosteroids, such as fluticasone and budesonide, have shown small benefits in FeVO. The majority of their benefit occurs in reducing the severity of exacerbations, not the number of exacerbations. D. Anticholinergics, for example, ipratropium bromide, tiotropium bromide, atropine. 1 indications. Anticholinergics may be used as first-line bronchodilators or in conjunction with agonists in the treatment of COPD, because these agents are the most potent bronchodilators for the condition. 2. Mechanism of action. Ipratropium bromide, tiotropium bromide, and atropine produce bronchodilation by competitively inhibiting cholinergic responses. Ipratropium bromide and tiotropium bromide also reduce sputum volume without altering viscosity. Some studies have shown an increased response to these agents in COPD when they are combined with agonists. Tiotropium has greater affinity for cholinergic receptors than ipratropium. 3. Administration and dosage. Ipratropium bromide is 3 to 5 times more potent and has significantly fewer side effects than atropine, which is rarely used today since the development of nebulized ipratropium. B. Initial MDI dosing of ipratropium bromide is 2 inhalations 40 grams 4 times daily, but dosing can be increased to 6 inhalations 4 times daily without significant risk. These higher doses are often required to achieve therapeutic benefit. Administration should be via NDI with spacer or NDI alone using a closed-mouth technique. C. Dosing of ipratropium bromide solution is 500 grams to 2.5 milliliters, 1 unit dose vial, or more via nebulizer 4 times daily. D. Tiotropium bromide capsules contain 22.5 grams tiotropium bromide monohydrate, equivalent to 18 grams tiotropium. Tiotropium is an inhalation powder contained in a hard capsule. It should be administered once daily only via a HandiHaler device, which delivers 10 grams tiotropium. Patients should generally not be placed on both ipratropium and tiotropium because of the increased risk of anticholinergic side effects, and no additional bronchodilation is likely achieved by adding ipratropium. For example, if a COPD patient is currently on ipratropium albuterol, Tombivent, Duon-B, and tiotropium is started, the albuterol should be continued as the short-acting bronchodilator and ipratropium discontinued. 856 Chapter 41-2. G. Table 41-9. Therapy at each stage of COPD. Moderate, old, 0, at risk. I, mild, the B, that's severe. 0, at risk. I, mild, moderate. Very severe. I, very severe. Characteristics. Chronic symptoms. Fevonly FVC. 70%. Fevonly 30%. Fevonly FVC. 70%. Exposure to risk factors. Favon. 80%. 50% Favon. 50%, 30%, Favon, 50%, Favon, 30% or Favon, 50%, normal spirometry, with or without, with or without, with or without, predicted plus chronic. Symptoms. Symptoms. Respiratory failure, avoidance of risk factors, serin, influenza vaccination ad, short-acting, bronchodilator. When needed, add regular treatment with one or more. Long-acting bronchodilators, add rehabilitation, add inhaled glucocorticosteroids if repeated exacerbations. Add long-term oxygen if chronic respiratory failure. Consider surgical treatments. Favone, forced expiratory volume and 1 SEC. FIV, forced vital capacity. Reprinted with permission from Global Initiative for Chronic Obstructive Lung Disease. Gold. Global Strategy for the Diagnosis, Management, and Prevention of Chronic Obstructive Pulmonary Disease. Updated 2006. http goldtopd.org. Asthma and Chronic Obstructive Pulmonary Disease 857. Agonists CI. Table 41-4. 1 indications. 2 agonists may be used as first-line bronchodilators or in conjunction with anticholinergic agents in the maintenance treatment of COPD. Short-acting agents are used regularly or on an as-needed basis for symptoms. Some patients may respond clinically to the prolonged treatment with 2 agonists even after demonstrating lack of acute reversibility. Spirometry testing showing 12% or 200 ml increase in Favone to short-acting agents. 2. Mechanism of action. 2 agonists relieve dyspnea caused by airway obstruction, although the response is usually not as significant as in patients with asthma. These agents may also increase mucociliary clearance by stimulating ciliary activity, helps patients expectorate sputum. 3. Administration and dosage. Any 2 agonists are administered via inhalation. For example, DPI, nebulizer, MDI with or with autospacer. Unless the patient cannot use the drug properly, then an oral agent is used cautiously. B. 2 agonists of the same duration should not be used in combination because an adequate dose of a single agent provides peak bronchodilation. However, it is reasonable to administer a long-acting product, for example, salmeterol, formoterol, on a regular basis with a short-acting agent reserved for as-needed or rescue therapy. C. Salmeterol, formoterol, or formoterol, long-acting agonist, are administered twice daily. Indacterol, Arcapta, is a recently marketed long-acting agonist that is administered once daily as a dry powder inhaler. They may also be used in combination with ipratropium bromide or tiotropium. Neither agent is used on an as-needed basis for rescue therapy, although formoterol does have a rapid onset of action. D. Inhaler devices that require a rapid inspiratory rate may result in suboptimal lung deposition in the COPD patient with limited inspiratory capacity. An NDI or nebulizer may be more optimal in this type of patient. F. Theophylline, CI, thies. Theophylline compounds typically are added to the drug regimen after an unsuccessful trial of ipratropium bromide and adrenergics. Theophylline appears to have a greater clinical role in COPD than in asthma. Other similar agents. Phosphodiesterase inhibitors are in development. SE2 agonist or SA anticholinergic, albuterol or levobuterol or ipratropium. SE bronchodilator combination, albuterol or levobuterol ipratropium. SA2 agonist, SA anticholinergic. LA2 agonist, albuterol or levobuterol ipratropium. Salmeterol or formoterol. SA2 agonist, SA anticholinergic. LA2 agonist, PD4 inhibitor. albuterol or levobuterol ipratropium salmeterol or formoterol theophylline. SA2 agonist LA anticholinergic, albuterol or levobuterol tiotropium. SA2 agonist LA. Stepped care approach to bronchodilators in COPD. Figure 41-4. Stepped care approach to bronchodilators in COPD. AC, anticholinergic, LA, long-acting, PD, phosphodiesterase, ASA, short-acting. 858 Chapter 41-2. G. Buterol or levobuterol ipratropium salmeterol or formoterol theophylline. Figure 41-4. Stepped care approach to bronchodilators in regularly or on an as-needed basis for symptoms, or in conjunction with anticholinergic agents and the maintenance treatment of COPD. Short-acting agents are used regularly. Figure 41-4. Stepped care approach to bronchodilators in COPD. Care approach to bronchodilators. Agonist LA anticholinergic, albuterol or levobuterol tiotropium. SA2 agonist LAAC La2 agonist, albuterol or levobuterol tiotropium. Salmeterol or formoterol. SA2 agonist LACLA2 agonist PD4 inhibitor, albuterol or levobuterol tiotropium salmeterol or formoterol theophylline. Figure 41-4. Stepped care approach to bronchodilators in COPD. AC, anticholinergic, LA, long-acting, PD, phosphodiesterase, ASA, short-acting. 858 Chapter 41-2. G. Mechanism of action. In COPD, theophylline compounds are used because they increase mucociliary clearance, stimulate the respiratory drive, enhance diaphragmatic contractility, improve the ventricular ejection fraction, and stimulate renal diuresis. Their bronchodilator properties are modest, at best. Theophylline may be used in lieu of other long-acting bronchodilators, or in combination. 3. Administration and dosage. A trial of 1 to 2 months with the serum drug level maintained at 5 to 12 grams cml and maximized. Because of the non-bronchodilator effects of methylxanthines, they may be continued in the face of a clinical response, even in the absence of improved favone. B. If no change occurs in the patient's clinical condition and/or favone, theophylline therapy should be discontinued owing to the potential for side effects. 4. Precautions and monitoring effects. Serum drug levels should be closely monitored in all patients, especially those with signs of toxicity, tachycardia, nausea, vomiting, as well as with liver impairment, congestive heart failure, and/or cor pulmonale as a result of reduced theophylline metabolism. Potential drug interactions, for example, with ciprofloxacin, may warrant blood testing. G. Roflumilast Daliris Boland indication. Roflumilast is indicated as a treatment to reduce the risk of COPD exacerbations in patients with severe COPD associated with chronic bronchitis. 2. Mechanism of action. Roflumilast is a long-acting selective PE4 inhibitor that provides anti-inflammatory effects and mild bronchodilator effects. 3. Administration and dosage. The dose of roflumilast is 500 mcg once daily, with or without food. 4. Precautions and monitoring. The primary side effects of roflumilast are GI intolerance, diarrhea, nausea. Weight loss, averaging 5 lb, was seen in clinical trials. The PI warns that suicidality was reported in a small number of patients. The relationship with roflumilast is unclear. Drug interactions through CYP450 may occur, analogous to those seen with theophylline. Corticosteroids CI Table 41-5. One indication say systemic corticosteroids, preferably oral, are indicated in the treatment of acute COPD exacerbations and chronically in some severe patients. B. Inhaled corticosteroids play a less prominent role in COPD than in asthma. C. Candidates for prolonged use of inhaled corticosteroid therapy should be symptomatic and have a documented spirometric response, that is, an increase in FeVO of at least 15% and 200 milliliters after 6 weeks to 3 months of use. Have an FeVO 50% predicted, with a history of repeated exacerbations requiring systemic corticosteroids or antibiotics. D. Long-term use of systemic steroids should be avoided if possible. Osteoporosis of the spine and ribs is especially common in COPD patients receiving frequent or maintenance systemic steroids. It has been recently recognized that inhaled steroids increase the risk of bacterial pneumonia in COPD patients. 2. Administration and dosage for oral use in outpatient management of acute exacerbations. Prednisolone is administered at a dosage of 40 mg day for 10 days. B. The dose of oral, for example, prednisolone or intravenous corticosteroids, for example, methylprednisolone, for hospital management of acute COPD exacerbations is not established. However, doses and duration of therapy should be limited. For example, 30 to 40 milligrams a day of prednisolone for 10 to 14 days to avoid significant adverse effects. C. In COPD, inhaled steroids are not as efficacious as in asthma patients. In appropriate patients, corticosteroids may be administered via DPI or NDI with spacer. E. Response to oral corticosteroids does not predict response to inhaled corticosteroids. 5. Medium doses of inhaled corticosteroids are recommended for COPD. For example, Flovin. 110 grams, 2 puffs twice a day, or the combination of Advair 250 grams, 1 puff twice a day. G. Inhaler devices that require a rapid inspiratory rate, for example, Pulmicort Flexhaler, are generally not desirable in COPD patients. Asthma and chronic obstructive pulmonary disease 859. Antibiotics. 1. Indications. Antibiotics are used to treat exacerbations with suspected infection as evidenced by an increase in volume or change in color or viscosity of the sputum, along with dyspnea. B. Prevention of infection with chronic antibiotic therapy is controversial and should be considered only in patients with multiple exacerbations annually, that is, more than 2 per year. Antibiotic therapy. Anti-inflammatory antibiotic treatment of exacerbations in patients with COPD is recommended when there is evidence of worsening dyspnea and cough with purulent sputum and increased sputum volume. Hospital or laboratory antibiograms should be reviewed when selecting an appropriate agent for S. pneumoniae, M. Catarrhalis and H. Influenzae. 2. Agents may include either a second-generation cephalosporin, for example, cefuroxime, cefaclor, trimethoprim sulfamethoxazole, a lactam with or without a lactamase inhibitor, for example, amoxicillin, amoxicillin clavulinate, macrolides, azithromycin zithromax, or an oral fluoroquinolone, ciprofloxacin cipro, levofloxacin levocaine. Note that recent evidence indicates chronic macrolides may have a role to decrease COPD exacerbations. If infection with M. pneumoniae or Legionella pneumophila is a concern, although uncommon in COPD flares, a macrolide or fluoroquinolone may be added. B. Antibiotic treatment of pneumonia in hospitalized patients with COPD includes either a second or third generation cephalosporin, for example, cefuroxime, ceftriaxone, cefotaxime, or a lactam with or without a lactamase inhibitor, for example, amoxicillin clavulinate augmentin, piperacillin tazobactam, zosyn, a macrolide or fluoroquinolone. C. COPD exacerbations are treated for 3 to 10 days, depending on the agent used, for example, moxifloxacin 400 mg for 5 days, and the patient. J. Mucolytics, for example, oral N-acetylcysteine, may improve sputum clearance and disrupt mucus plugs. K. Expectorants, for example, guaifenesin, may be used. Potassium iodide should be avoided because of side effects associated with iodine therapy. L. Antioxidants, for example, oral N-acetylcysteine, may reduce exacerbation frequency. M. Influenza virus vaccine is recommended because of its ability to reduce death and serious illness by almost 50%. 2. Non-pharmacological therapy. A. Vaccinations. 1. Influenza vaccination administered each fall/winter. Polyvalent pneumococcal vaccine is recommended by the American Thoracic Society. B. Oxygen therapy. 1. Recommended for hypoxemia chronically or during exacerbations. Currently recommended to administer oxygen at least 15 hr a day. 2. Reverses hypoxemia, particularly at night and during exercise. 3. Indications for home oxygen treatment include A. PaO2 55 megameters Hg or CO2 88%, B. PaO2 of 55 to 60 megameters Hg or CO2 89% with evidence of core pulmonale, pulmonary hypertension, or polycythemia, hematocrit 55%. 4. Patients hospitalized for COPD exacerbations should receive controlled oxygen to keep PaO2 60 megameters Hg or CO2 90%. Arterial blood gas (ABG) tests may be performed 30 mins after placing the patient on oxygen to identify and minimize CO2 retention. C. Chest physiotherapy loosens secretions, helps re-expand the lungs, and increases the efficacy of respiratory muscle use. Techniques include postural drainage, chest percussion and vibration, coughing, and deep breathing. These efforts may help patients with lobar atelectasis or who produce large quantities, that is, 25 milliliters a day, of sputum. 860 Chapter 41 Sec. G. D. Physical rehabilitation improves the patient's exercise tolerance and quality of life. A pulmonary rehabilitation program usually includes physical conditioning and social, psychological, and nutritional interventions. This can be an effective intervention E. Smoking cessation and avoidance of other irritants has been shown to slow the rate of decline in favone in COPD patients. It is obviously one of the most important interventions. Nicotine gum patches, inhalers, lozenges, bupropion, varenicline, Chantix, and Claudine may be useful in smoking cessation. Behavior intervention significantly enhances the effectiveness of pharmacological therapy in smoking cessation. F. Surgery. There is a growing body of evidence that lung volume reduction surgery may be beneficial to patients with severe emphysema. Clinical trials have now delineated proper patient selection for this type of surgery. Lung transplantation is also performed in selected patients. H. Complications of COPD-1. Pulmonary hypertension. With decreased pulmonary vascular bed space owing to lung congestion, pulmonary arterial pressure increases. In some cases, pressure increases enough to cause cor pulmonale, right ventricular hypertrophy, with consequent heart failure. 2. Acute respiratory failure. In advanced stages of COPD, the brain's respiratory center may become seriously compromised, leading to poor cerebral oxygenation and an increased PaCO2 level. Hypoxia and respiratory acidosis may ensue. If the condition progresses, respiratory failure occurs. 3. Infection. In chronic bronchitis, trapping of excessive mucus, air, and bacteria in the tracheobronchial tree sets the stage for infection. In addition, impairment of coughing and deep breathing, which normally cleanses the lungs, leads to destruction of respiratory cilia. Once an infection sets in, reinfection can easily occur. 4. Polycythemia. An increase in red blood cells infrequently can lead to hypercoagulable states, embolism, and stroke. This happens uncommonly today due to the widespread use of supplemental oxygen in COPD patients. Study questions. Directions for questions 1-7. Each of the questions, statements, or incomplete statements in this section can be correctly answered or completed by one of the suggested answers or phrases. Choose the best answer. 1. The symptoms of allergen-mediated asthma result from which of the following? Increased release of mediators from mast cells. B. Increased adrenergic responsiveness of the airways. C. Increased vascular permeability of bronchial tissue. D. Decreased calcium influx into the mast cells. Decreased prostaglandin production. 2. Acute exacerbations of asthma can be triggered by all of the following except bacterial or viral pneumonia. B. Hypersensitivity reaction to penicillin. C. Discontinuation of asthma medication. D. Hot, dry weather. Stressful emotional events. 3. A 45-year-old male with a history of asthma has a peak expiratory flow rate, PEFR of 65%, nocturnal wheezing once a month, and daytime wheezing usually less than twice a week. According to the National Institutes of Health, NIH guidelines for the treatment of asthma, he has which type? A. Mild intermittent. B. Mild persistent. Moderate persistent. D. Severe persistent. 4. The patient in question 3 should be treated with which two agents? A. Inhaled steroid and ipratropium. B. Inhaled steroid and albuterol MDI, as needed. C. Inhaled steroid and aspirin. Asthma and chronic obstructive pulmonary disease 861. 5. A 15-year-old female is brought to the emergency department. She is breathing 30 times per minute, is unable to speak in full sentences, and has a peak expiratory flow rate, PEFR 50% predicted. The preferred first-line therapy for her asthma exacerbation is A. Theophylline, B. Agonist, C. Corticosteroid, B. Cromolyn sodium, E. A and B, B and C. 6. The primary goals of asthma therapy in an adult patient include all of the following except A. Maintain normal activity levels. Maintain control of symptoms. Avoid adverse effects of asthma medications. Prevent acute exacerbations and chronic symptoms. Prevent destruction of lung tissue. 7. Which of the following tests is used at home to assess therapy and determine if a patient with asthma should seek emergency care? A. Forced expiratory volume in 1 SEC. FIVONE. Forced vital capacity. FVC, total lung capacity, TLC. Peak expiratory flow rate, PEFR, residual volume. Directions for question 8. The incomplete statement in this section can be correctly answered or completed by one or more of the suggested answers. Choose the answer. If I only is correct, B if the third only is correct, C if I and second are correct, D if second and the third are correct, E if I, second and third are correct. 8. The disease process of chronic bronchitis is characterized by: first, the destruction of central and peripheral portions of the acinus. 2. An increased number of mucus glands and goblet cells. 3rd, edema and inflammation of the bronchioles. Directions for questions 9 and 11. Each description in this section is most closely associated with one of the following agents. The agents may be used more than once or not at all. Choose the best answer. It. Cimetidine, B. Albuterol, C. Aprotropium bromide, D. Epinephrine, E. Atropine. 9. Decreases theophylline clearance. 10. Has anticholinergic activity with few side effects. 11. Has high 2-adrenergic selectivity. Answers and explanations. 1. The answer is a CIF, figure 41-1. In asthma, airborne antigen binds to the mast cell, activating the Ig-mediated process. Mediators, for example, histamine, leukotrienes, Prostaglandins are then released, causing bronchoconstriction and tissue edema. 2. The answer is D. CIT, figure 41-1. Exacerbations of asthma can be triggered by allergens, respiratory infections, occupational stimuli, for example, fumes from gasoline or paint, emotions, and environmental factors. Studies have shown that cold air can cause release of mast cell mediators by an undetermined mechanism. Hot, dry air does not cause this release. 3. The answer is C. See table 41-3. The patient has moderate persistent asthma. All three parameters are consistent with mild persistent asthma. If any one of the three parameters indicated moderate persistent asthma, then the patient would be classified as moderate asthma, P for 65%. 4. The answer is B. See figure 41-3. Inhaled steroids are the anti-inflammatory drug of choice owing to proven efficacy. All patients should be prescribed a short-acting 2 agonist to use as rescue therapy for worsening symptoms. If chronic symptoms worsen, a long-acting 2 agonist can be added, for example, Advair. Remember that increasing the dose of the inhaled and released, causing bronchoconstriction and tissue edema. 2. The answer is D. CIT, figure 41-1. E. See figure 41-3. Inhaled steroids are the anti-inflammatory drug of choice owing to proven efficacy. All patients should be prescribed a short-acting 2 agonist to use as rescue therapy for worsening symptoms. If chronic symptoms worsen, a long-acting 2 agonist can be added, for example, Advair. Remember that increasing the dose of the inhaled steroid may not improve symptoms. A long-acting bronchodilator is more likely to do so. (862), Chapter 41. 5. The answer is F. See figure 41-3. Patient is obviously in respiratory distress. Aggressive treatment with oxygen, systemic steroids, and short-acting bronchodilators is indicated. Ipratropium could also be added to the albuterol in the acute setting. 6. The answer is E. CIF. I. Asthma is characterized by reversible airway obstruction in response to specific stimuli.